So on the policy side, we focus here specifically within the Alliance on how do we actually address those issues that are really barriers to adoption in this technology. And that happens at three different levels. So there's one at the policy, at the federal level, which is how do we make sure that the legislative branches of government certainly have the right pieces of puzzle in play. We focused on that about 3 years ago when the ACA, the Accountable Care Act, was actually being passed, and in addition to that, the high-tech, to ensure that the funding was going to be available and that we were able to actually include these types of technologies as a new model for healthcare moving forward. It actually did fund some demonstration projects, but more importantly, it actually led to the legislation around Meaningful Use 3 out of the High-Tech Act. And Meaningful Use 3 really is focused on that patient self-reported data and being able to allow physicians to be engaged in that area. The second factorial that we have to take a look at is the regulatory components of that, and that is the FDA, making sure that the FDA processes are in place and appropriate to be able to use these technologies. Because this is completely a new area for the FDA to understand and how to implement these types of capabilities. We've hosted a couple of activities with them, and over the last 3 years, it's resulted in some outputs such as the mobile medical guidance that came out in 2011. And we are expecting to hear more from the FDA this year around how they look at placing that activity in play, how to really get these devices in play. This also plays into the FCC as well, because we're now using mobile technology, so therefore it's more wireless-based types of capabilities. We saw some advent of some of the new policies from the M-band architecture that they just recently released, which is a specific spectrum. But more importantly, we're just recently seeing that the FCC is going to be active again in this area by hiring a doctor to focus on this type of activity as well. So I think that that's the second component. The third thing that we have to focus on here too is state-by-state legislative activity. And in certain areas of the U.S., it actually is somewhat still prohibited to really use this technology effectively across a wide spectrum. So where I live in Texas, we're focusing on some of the legislative activity to ensure that we can use this technology in place and have that available, because there are some certain state restrictions that limit what we can do with this technology. So we focus specifically on those three big, broad topics on policy. But when you take a look at those that have actually been approved by the FDA as being usable, that's less than 100. So what we have is a very limited data set of applications that have actually gone through the rigors, as you mentioned, of the clinical scientific studies, but to actually prove some level of efficacy in the back end. And so there is this dichotomy, because the medical community is saying, I need something that's proven, but the consumer community is used to, I'm going to go out and download whatever I want because I think it looks cool today and I'm going to use it. And we have to figure out sort of that branching between those two activities and what's going to really allow us to move between what we consider to be a free-for-all, which is not what we completely want, because we are dealing with medical conditions, we are dealing with medical serious issues here, and that have some serious outcomes, and we don't want the essence going back to the snake oil days of trying to sell an application. Yeah. As being able to be treatable in this case. So we want to make sure that we get the right types of policies in place, and that sort of led to that there's a very limited set for the physicians to use today, and there's a whole wild west of applications that consumers are looking at today. The question is, do we really see a difference between those apps that are simply presenting, they're basically a user interface that just represents the data from the device itself, versus those that actually take the data and do something with it. So they actually calculate a measure, and in essence what the term here is that it has some clinical decision support capability in it. And the answer is yes. Those that, the FDA as part of their mobile medical guidance is already starting to look at this aspect. If you're simply only passing data, really all it is you're repeating the exact same data that's in the device, that's low risk, and they don't really have you basically can pass an FDA certification in that case. If you're doing something with that data and you're making an analysis and passing judgment on that data, you clearly have stepped into the realm of an FDA-regulated application and have to go through the rigorous effects of what the FDA is going to be put in place.
We have another question.
Yes. So the question I have is, are we looking at FDA to be that standardized body to make those regulations? Because there's a constant argument between the public and the private, right? So does FDA set the baseline, and then we have some other entities setting the standards? So who's going to set the standards?
So I think that we have three bodies involved in that. So the FDA has been very clear this is their purvey when it comes to medical devices. that this is where they sit in this spectrum of space, and that they're going to really take action and enforce their, what is considered to be sort of their turf on the medical devices. The second agency is the FCC. They have some relevant expertise in this area and are truly looking at the spectrum analysis of this and how is the spectrum going to play into, let's say, rural broadband initiatives and or airways within the hospital and spectrum that we need to release so that we don't end up with a crowded 2.4 gigahertz band kind of thing. And the third organization is ONC. So ONC is going to be setting the standards for what is the interconnect of that data element. So, am I using HL7? In what version of HL7 am I using? How am I going to connect that data from point A to point B? So we have three bodies that are all sort of at the table saying we are all going to set some level of regulation, some which will potentially be overlapping in this case. But in a primary sense, I think the FDA probably has the primary area of responsibility because this is a medical application, it will be considered at some point a medical device.
Yeah, a lot of it has to do, so from a app development standpoint, if I'm going to design an app, I have to be aware of which realm I'm going to go into. Am I going to go into the realm of it just being a entertainment, gaming, fitness type of thing where it's fun, it might help, it might not? Or am I actually going to say I want to make an impact on diabetes? Because that will guide your business plan, and that will affect how, when the FDA does come down with their guidance, because they've given a little bit snippets of what they are not going to touch, but they haven't said how they're going to handle what they will touch. And I think part of the reason of that is because it's so complicated. You want to make sure you grasp it and give a recommendation that's going to be broad enough, but enough for continued innovation as well. So I'm glad I'm not in that position to try to make that guidance, because it's going to be very, very complicated. So it's very easy to say we're not going to cover glucometer, just straight transmissions. We're not going to cover. And there's a list of things, and I'm blanking out right now, so I apologize on that. But there is a list of things that they say that they will not touch, but they haven't said how or what they will cover. And like you said, there's already companies that have made that business decision of, I don't know what they're going to do, but I do know I want to get FDA 401 approval. So there are companies that have apps or add-on devices to those apps, because you have to remember, smartphones is not just about the app. We have technology that's available that goes onto those smartphones that now changes it. So now the device that you carry around has become it's become a medical device. I can check my heart rhythm. So now is my phone and the device both medical device, or is it just the one? No, it's technically just the one, but the persons, when they put in their applications, want it for both, and it's a very complicated area. But going back to your point of the apps, who do we listen to? It's coming, and from a clinical side, when patients ask me what should I do, I go back to just sort of the gaming, sort of try out what you want. And in the 90s, when the internet first came about and patients came to me with lists of, I read about diabetes on the internet. I had this long list of things. It's sort of kind of like that. I just read about this on my app. What is, and it's that dialogue, it's that interaction. I think as we evolve over the next 3, 4, 5, however long it takes, that will evolve. That answer will evolve itself.
Right. So actually, I have a follow-up question on the lines of what you are saying. So great. So FDA, FCC, ONC, they are the operational, technical outline. But that still doesn't tell me, based on efficacy or outcome, which app is better or not. And just to give you an example, Haptik, the company Haptik, which is doing a lot of curation in this field, and they are coming up with these standards of certified app. So, who's going to take the lead on that? Public sector, the private sector, and is there going to be a lot of fragmentation around this standardization and efficacy? And how do you measure that?
Well, I think you end up with any normal business cycle in this type of an arrangement. So you're going to see thousands of apps appear. Some will become very popular, and some will become, as understood in the market space, are going to say, okay, these didn't work very well. And it's sort of a normal hype cycle whenever you take a look at, let's look at the example of electronic health records vendors. We saw a slow increase of adoption of electronic health record vendors over the last few years. We saw like in the neighborhood of 500 different vendors appear once meaningful use came into effect. And now we're seeing a very much so a rapid consolidation of the industry around probably a top 10 type sort of an aspect. That happens in the app world as well. When we first got the iOS phones, we all went out there and started playing games. But hey, this little thing with the Angry Birds started to look kind of cool, and we all started downloading Angry Birds, and it sort of became the leading application out there. And I think it's sort of, we start to see what really becomes what people are going to want to use, what people do use, and it's going to be that social circle. Who's getting recommended? What are you recommending from being able to use that? And then ultimately, it's going to be about apps that have a stickiness factor. What are the apps that we're going to continue to use over a period of time? I can download, and I have downloaded hundreds of apps, and some of these medical apps. Looked at them, tried to use them for a little while, and just realized that they're very singular focused. They're only for keeping track of specific dietary function things, or very much so just where I'm going today. I want something that's more integrated. I want something that's more a bigger approach to what I'm doing in my life and integrating much more data than that. So I think that as we start to see these robust level 2 apps begin to, moving from level 1 to level 2, or new ones coming out entirely, I think is when you're going to start to see that take off. We just haven't seen that yet, but that's not to say it's not happening. It's just that we just haven't seen it yet. It's sort of real early in this industry. Curation is going to be a problem, though. I think that there is no true ultimately, while Haptik is doing some of that right now for the medical community, we're not going to see that for the consumer community, and rightfully so. I think it's what are the consumers going to want to use on their own, and we shouldn't be necessarily trying to limit that market.
I think your question was about, is someone going to do efficacy? And I don't think that they are. I think that's a tough one to do. I think, to Chuck's point, you'll get the good ones, everybody uses kind of apps, but I'm not sure anyone's going to take on what's more effective than the other. That's a clinical decision, and that's not normally in the space that we sit in. You do, but most of us don't. And that one's more effective than another one.
I think the question is the key. So if you want, like with Haptik, they're certifying apps. So they're saying that this is a app that works, it does what it says it does, but in terms of efficacy, which has the better outcomes, which is compared to, those require clinical studies. So that's a whole separate question. Is there a business plan around that? Who knows? In terms of even certification, just because Haptik says they're going to certify it, why do I have to listen to the Haptik certification? It doesn't mean anything really. It just means that someone who I don't know who they are went through and said, this is a plus. I don't know their backgrounds. I don't know who they're, they haven't disclosed to me the whole transparency of the whole process. Who's the people that are reviewing these apps? What's the process that they're reviewing their apps? There's a lot of stuff that you'd want to know about that they may or may not reveal.
I think the part that is interesting, though, is over time, when with the web initially, I think patients used to come in with printouts, right? They'd come in with a no-name printout, and then it became mHealth, and then it became WebMD, and then you guys probably saw the same websites getting printed out. There is a platform leader paradigm that happens, a pattern. Sooner or later, 4 or 5 names become dominant, right? And then when I used to go to the doctor's office, the doctor would give me the WebMD printout. So it took a while for folks to come in with printouts, and now I still get a WebMD printout actually of here's how you should do your stretches, or here's other things you need to do, things you need to avoid, etc., etc. And it doesn't tend to be the more acute cases, but sort of the outpatient self-managed portion of it. And I think there's a huge opportunity there first with apps, because what's happening is the patients are coming in with an app now, not a printout, and it's live. They can tap to the next thing. They can switch it over. It's a much richer experience. And so I think clinicians are going to have to react to that, because now it's a dynamic conversation. It's not a printout, and now you're not going to walk out with a printout. And I think the curation is probably not going to happen in any formal way. It's impossible. The scalability of curating 10,000 apps every week that are coming out is just not going to happen. And the FDA is going to have to narrow down their scope because they have the same scalability issues. They can't measure everything, so it's probably going to create a backlog, right? We're going to get to you when we get to you, because you're diagnosing, you're doing decision support, so you're going to have to wait in line like everybody else. In the meantime, though, there's a porous wall of apps coming in to the patient's life and the clinician's life, and what do you do about those? And I think this is where you have to take a step back and say, all right, are we going to crowdsource something so that we create an influence of the dynamic? Are there going to be 20 apps that, for certain indications, they just pop up at the top? They may or may not be FDA certified, but they've become sort of common, trusted sources like WebMD. iTriage is another one that I hear getting recommended a lot by clinicians, by other patients, and so you get brand values and brand dynamics that just happen. And I think the question is, what do you do about that? Is that okay? Is there a policy around that, or is that just pure capitalism and that's the way it works?
Do you see a trend happening with facilities as far as different healthcare systems building their own apps so they can manage some of the things you're talking about, where you're going to WebMD to get these printouts instead of getting it from your doctor, where they would prescribe something and say, I want you to follow this plan, and then you're able to actually send that to them or to push them to your healthcare system's app? Is that something that I know that a couple of our clients are working on things like that, or is that something maybe you've seen Verizon?
Yeah, I would say yes. I mean, we've seen that for many years already. So we've seen the integration of healthcare content on their their internet. So a lot of the major healthcare providers today, wherever you want to go in the U.S., for example, let's just pick Kaiser Permanente, have had a source of known content that they put on their website. What the app's doing is just making that mobile friendly. And making it accessible from them, what they've already created. And then you have organizations like Mayo who are generating a significant chunk of that content on their own already. And so it's just, what you're doing is you're seeing their apps basically point back to that and basically make it it's a little bit more mobile in that sense.
I would actually call it more portal than app. There are some that do actual apps, but most of it is entering into their internet or intranet that is actually housing all that data.
So like My Charge or something like that. So providing an app to take them to that information, so it's not stored digitally on their phone.
Exactly.
Not compliant. So actually, you see more of the portal, I guess, being built by healthcare systems.
Absolutely, right. Absolutely.
So obviously Mayo and people like that, Johns Hopkins, people that have that kind of dollars. Is there ways that some of the smaller systems could look into things like that, or
they're easy to do. They're easy to do.
Yeah, they're simple to do, but also there's a driver behind it. It's called Stage 2 and Stage 3 meaningful use. So you have to provide that access to information. Whether do it via a portal or via a mobile portal, because now, as long as you create your web interface as mobile friendly, all you need is a shortcut on your phone, and you've had an app. And there's a lot of apps that are not really apps; they're just directing you to the website.
Yeah, I think that to your question specifically, I think that yes, there are resources here on the show floor that provide that content in a basic format that is unbranded, that you can rebrand. In essence, it's a white label format that you can rebrand with your corporate logos, your corporate systems. When I say corporate, that's any healthcare provider, and I mean all the way down to the physician office level, who wants to be able to provide that content. They can brand it for you in that sense. So there are multiples of those out here on the show floor, and I think that's the way that we're going to see that continue to move forward, because these resources become trusted sources of content. They've already done like a Walters Kluwer, so they're the researchers out there, so they already have an unbranded portal that you can integrate into your healthcare set of data moving forward in that sense. So
I think inevitably folks are browsing more on their mobile phones. So Kaiser did a study recently. They've only had their mobile presence, which is an app and a mobile friendly website. And I think within 6 to 8 months, their traffic on that particular property turned to about 24% mobile. So it's a pretty high number. And the new study also showed that mobile as an adoption technology in terms of adoption barriers, the barrier doesn't really kick in age-wise until 84, 85 years old. So we're starting to dispel sort of the early reaction that the healthcare industry had, which is not everybody has a smartphone. Okay, that's no longer the case. You know, there are certain demographics that it works for. Well, there's actually, you know, you could see it. Technographics of certain minority groups and so on is actually much higher adoption of mobile over traditional computing. So that's not a real issue. Dealing with the age discussion and challenge, not so much. At least not what consumer behavior is showing. So not having a mobile website is probably sort of like total faux pas over the next few years. But now what do you do to become an influencer of where they go, which is really a marketing problem that now healthcare providers have to sort of wrestle in and have a place in that patient's life right next to Angry Birds or whatever the flavor of the year is. How do they just stay relevant so that you reduce the amount of noise that people come in with and say, I tried this and I tried that. You reduce the scenario that you said. Earlier on, people used to come with 50 things they read on the internet, and you say, all right, let me dumb it down. Let me just dumb it down to these are the right ones. I see these a lot. I've taken a look at these, or they're covered by the New England Journal of Medicine, etc. It's a little more credible. Why don't you look at these? I think that's the role that clinicians can play here.
I think I read Verizon actually for the first time ever, was it last year, smartphones outsold every other phone with 55% adoption of the smartphones. So is there, in your opinions, is there a best practice for a facility that might not be maybe moving toward a mobile technology, moving toward something to get in touch with their patients? Is there steps that they should look at from the front end and kind of build and go forward?
Well, certainly. I mean, immediately it's your social networking aspect. So, what are you doing with Facebook? What are you doing with, perhaps Twitter and some of the other social networking feeds? Because I think that's the first, that's where we see a lot of, at least integration points begin with that sort of communication to the community. You may not be delivering a mobile app, but you start to want to deliver a mobile message. And that is that, hey, we're out here, we're going to provide you content, and it makes it relevant to those social networking circles.
It makes the provider network or whoever's doing it more relevant to their patients. It's a very competitive world out there. Most markets have multiple provider networks trying to compete. I don't find, I'm lucky enough to be out in the field quite a bit. I don't find many that don't have a mobile plan already in place. Because of meaningful use, but the second, it's being demanded by their patients. So.
And what's the demand from the provider standpoint? Are they pushing for devices? And we talked a little bit about bring your own app, but bring your own device and corporately owned.
We focus on this, and we've been working on this for about 6 years, and the answer is no. I mean, they're not the first adopters. They're not the one. I mean, they adopt themselves for their own convenience purposes, but they are completely resistant when it actually comes to seeing data. Because really, I don't know that we've effectively outlined what are the new workflows that this data is going to cause. It's one thing to say, hey, go out there, go out there as a consumer and get this app. You're going to be able to transfer all your measurements now to your physician. It's quite another to tell that phician, oh, by the way, tomorrow we're going to turn on. You're going to get 500 new observations from your patients, and it's a swarm of new data that they don't know how to deal with, and currently it's not outlined on how they're going to get reimbursed for that. And I think that's part of the issue is how do we effectively redesign the care team delivery. Reality is that 98% of that data doesn't need to go to the physician. It needs to go to a care team member who can make an evaluation of that data, but that requires you to have the right types of systems in place to be able to manage that data on the back end. And some of that is going to be an issue where we have to, where you have to be able to implement the right types of technology to be able to manage that data effectively.
What's the liability for the care team? I mean, if they were able to miss something or something
same
like
liability that they would have.
Is it a lot of the fear of that is that if you don't put it to the provider and there's something missed, the liability revolving around that is very high.
Well, but I think that our nursing architecture has been quite effective in being able to deal with long-term care patients and those patients who have been sent home specifically with patient monitoring. And we know how that works. We've seen there's monitoring, there's solutions out here on this floor that are showing that with nursing effectiveness today. And I think that level of training that the nurse receives is quite effective enough to be able to manage these populations. So let's think about it though. Primarily, if it's a critical patient, they probably wouldn't be at home to begin with. So the medical liability is probably decreased to begin with. If you had a level 1 patient who's coming out of a trauma center or just basically coming out of an ICU, you're not sending them home day 2. These are going to be people who are fairly stable and are low risk to some degree to go back to that home environment.
One thing that's usually left out in usually the whole care continuum is the home care agencies. And that's actually the part that's going to be driving a lot of this integration, because they're already in the homes, they already have the technology, they already have the staff and the protocols in place to address those specific things. So it's not that it's not already there, it's there, it's just integrating it now with technology. And some of the home care companies have invested in remote telemonitoring type devices because they know that they can provide the care that's required. Plus, from a home care side, they do get reimbursed for it. And so there is an investment for them to do it. And then from a liability standpoint, there's not that much change. It's still the same information. It's just that it might be a lot more information. So the liability standpoint, I really don't see it as changing very much.
Yeah, I mean, and you're asking a question about liability for missed data when we don't have that data today. I mean, we're the typical patient today is out of the physician office 99.6% of the time. We're not in front of that physician, we're not in front of that provider, that care organization. Even the diabetic is outside of the patient-physician relationship 98% of the time. So what we're trying to do is create a much richer data set that provides us much more feedback on what that individual's doing. And I think it's quite the opposite. I think we're going to be able to see things that were not occurring before that we can now predict and be able to help that individual avoid medical costs. And to the other point of that is, I think that what we're seeing is as we begin to accept more risk in the market space, ACOs, and a lot of those, what the ACO is driving is behind that risk management issue, is that you're going to see healthcare systems try to find these ways to be able to manage patients and organizations in a new and different way.
All right. Question, all right?
So I can speak up. So to tag on his question earlier about the three government bodies, do you think that they will come up collaboratively with a ruler or a measuring stick for application developers to go by when they continue to develop these applications? Do you not see that happening at all, or do you see that as being something that will eventually come down and it will come from all three bodies as this is kind of your ruler, your stick?
I definitely think that we'll see something this year, and it's going to come from the FDA because they're the primary ones that are going to be driving a lot of this initiative. ONC is going to tell you how to connect the data. FCC is going to say whether or not it can actually operate on that specific band or frequency, but the FDA is going to have the primary responsibility of saying this is the way that you deploy an app, and this is the way it's going to have to behave on the platform.
Pull in different information and put it together to be effective. You're not going to be able to see one collaborative, piece of information to make your decisions.
I think the key is going to be which area of focus is that app going to cover. Are you going to talk about improving diabetes? Or are you going to talk about improving medication compliance? Or are you going to talk about your activity level? So that's going to be that division still is there now, and when FDA it always gives you pretty clear criteria when it's there. So not knowing the details, I would say and assume based upon the past, they'll tell you this is how to do it. These are the numbers you need to do. This will pass. This will not pass. If this is the direction you want to go in, like they'll make it pretty clear. But defining that part of the role is what I think is a difficult part. Is how do you differentiate as we get to this nexus between a consumer app and a healthcare app? Because at the end result, you're still trying to take care of yourself better, right? So consumer side wellness still comes back into healthcare, but it's indirect. I think there was another.
Hi, can you hear me? This question is for Nancy. I was at a roundtable a few months ago with Peter Tippett and Kathy Brown. So I had some idea what the Verizons, the AT&Ts are planning to advance in advanced mobile health. And my question is, what can Verizon, what can they do on what they should do, given your reach of, tens of millions of consumers, not just from a carrier perspective, but can there be a data plan which is cheaper just to access health data, things like that? Because that's, you have so many firms here, but the really big ones with deep pockets and wide reach, I think should play a bigger role. Can you comment on that?
No. So we do have data plans specifically for devices now. that companies can use. So it's not the big data plan that you and I use for our phones. We have very specialized data plans for small bits of information, kind of movement of data. To Chuck's point, we're not, there's going to be special frequencies. When we're a big carrier with a lot of frequencies, we have a big band of frequencies that, at some point, will that be a healthcare ban or a use for that? That we talk about that, but I'm not sure if that's going to happen. But we have a very large focus for healthcare. So, and our CEO is very focused on what can we do to change healthcare. And for us, it's mostly enabling that data back and forth, right, over the networks that we have. Right, so we're not going to write apps. Verizon won't write apps. We have the phone, we have the network. Put them on and use them, and move the data between them, and we'll help secure them. And for some clients, get the data plans correct to what they need to do. I'm not sure.
Do you think you have to build bandwidth for video?
Did you have
sensing over Wi-Fi networks between physicians or physicians and patients?
Video?
Yeah, video, and again, it's being piloted by smaller companies on a smaller scale. And not just to go into telemedicine in all details, but I think that'll really add one more dimension to another thing.
Yeah, what we're seeing across the globe is, we have a global perspective here, so it's not only just a U.S. perspective, and we're seeing some of the other telcos in other parts of the globe really get actively engaged in this area. So I think what you're after here, and for example, Telefonica in Spain, where they've actually deployed and actually started hiring their own physicians and nursing staff to create a telemonitoring solution, and it's really a result of the fact that in some of their market spaces, they don't have health care. I mean, in Argentina, where they serve as one of their primary markets, there are places they don't have health care. With that said, though, I think that we are encouraging as our alliance is a marriage between what are considered the traditional telco market spaces and the healthcare provider organizations, and there's a couple of reasons for that. One is the telcos understand how to reach a very large market, a consumer market. They already have a billing platform to bill incrementally with these types of services. So it's a very much so something that the provider organizations don't have today. They don't. The healthcare entities themselves don't have that platform to incrementally bill. However, the ATTs, the Verizons of the world here don't have that brand recognition in healthcare, so they need the local provider, and you need the access to that local activity. So I think that what we're seeing in the next 5 to 10 years, or actually I say 5 years, 3 to 5 years, is going to be a marriage of the local healthcare systems and the local telco providers, because they both need each other to make this really happen truly in the market space.
And the struggle as to why it's going to take so long is the FDA and all of the FCC, because that's who judges us and runs us. We're heavily regulated, and if we start billing for healthcare on our bills, how does that tie in and make us responsible, right? So we have a huge cadre of lawyers that look at this all the time. I think our lawyers outnumber the actual employee base, but so that's a concern. To Chuck's point, it's absolutely, we have customers who are trying to do it all the time, and we talk about it all the time, but it then gets into a regulation type of thing.
From a clinical side, in terms of the bandwidth problems, I tweet when I go to conferences, and especially when you have 30,000+ people here, how many people have had their internet just sort of slow down on them and just can't get it stuck, email can't, right? So just with our basic necessities, with this volume of data, we have bandwidth problems. So going forward, most likely the things that are going to happen are more store and forward type of clinical data, right? So it's not going to be that kind of real-time data that is life critical, because then you shouldn't be out here, or there should be enough type of remote data that's coming, but it's store and forward. So it'll collect a lot of data, but it'll go there. So I don't think there's going to be that much of a problem with bandwidth, because it'll store it, and then when you get to your Wi-Fi, or you get home, or you get to your house, it's, I see the fixed stations getting more bandwidth, at home, like with Verizon, Fios, Comcast, whatever entity you want to choose. The bandwidth at homes will get bigger, and then you'll be able to download and send it in that way. So I used to think about the bandwidth problem, but I think, sort of stepping forward, that kind of data shouldn't be real time anyway, so it's going to be more store and forward. So there's going to be a sort of a plateau because everybody wants to send the data now because it's cool, and then they'll be like, wait, we don't need to, and then they'll store and forward, and then you have to go to the second question of, okay, now how do we secure that now? And make sure that it's HIPAA compliant and that interface. So there's, we're really in a lot of flux. There's a lot of change that's going to happen. So, what we talk about now, next year I could be telling you something completely different.
I think there's also a few other opportunities. So outside of what the FDA might regulate or what the FCC might regulate, I think there is an opportunity for big tech telcos as well, is to offer up things where providers, clinicians tend to struggle with. So more sophisticated security models, whether that's location-aware security for data that you don't actually want to leave the facility until it's approved, or onboard device security. So, hardware-based as opposed to software-based security that Verizon would have a lot of influence on in terms of what types of extra security features do they want to put in their handsets in the future. Understanding the local area network possibilities, whether that's Zigbee, UHF, Bluetooth, NFC, what to use for what, how well will the devices be equipped with that, and if they're not, what is the hardware add-on process to make that happen. So I think you're looking at so many form factors. Smartphones have been here for a while, tablets have been here for a while. We're getting into the world where form factors, watches I guess are next, that's the big buzz this year. But my point is, wearable computing, multiple mobility form factors is where big tech can really lend a hand. How do you manage that onslaught of different form factors in a clinical setting? And then you're not going to stop it proliferating because it didn't work with smartphones. Doctors were much further ahead than the regular consumer in smartphone adoption. Same with tablets. They were adopting at 2.5 times the rate tablets, the average doctor versus the average consumer. And so really when these things come out, I'm willing to bet a lot of doctors are going to want a Google Glass to have their consults and their data and and so on. They tend to be early adopters. And so how does big tech take advantage of that and create an orderly fashion in which to allow integration, data latency, data caching, different types of security that will make everyone comfortable, that it's just not going to walk out and be shared off the street, things like that. I think there's a lot that can be done there from a value add. And then as the data explosion starts or has already continues, you get into big data. And what does that really mean? And how can you make it easier for clinicians to be ready for the onslaught? How does that work? And again, big tech, I think, has a big role to play there because that's not going to be solved by the FDA, the FCC, or the clinical community. That's just not in their wheelhouse.
Kind of building off of that, I think that closer to 1 o'clock. So kind of go across the panel and go along those lines. What do you see as the future of mobile technology? What are some of the trends you're seeing? And can you kind of extrapolate on that a little bit as to what everybody can kind of be looking for over the next 5 to 10 years?
I think we've peaked on the sensor data. So I think sensor data is just going to get very cheap. So we're talking about commoditized sensor data, right? Sensors themselves are very, very cheap. So accelerometers already started off being cheap, and now I think they're dirt cheap. They're like microcents to get an accelerometer, right? So sensors, very cheap. Network connectivity and ubiquity, we're starting to get there, right? Thanks to Verizon and other folks, you are going to be connected most of your life, as you walk around and stuff. Yes, we have waning internet in big metal boxes like this, but there is pretty ubiquitous connectivity, and then ubiquitous computing as well. Smaller and smaller devices can do what a laptop could do 10 years ago. So now you have onboard computing, you have wearables, you have cheap sensors, and we're getting to a point where ubiquitous connectivity, not broadband, just connectivity, is available at all times. I think that opens up a very new sort of era of mobile health. And with things moving to the cloud, that becomes the partner in crime. So the initial funnel is mobility, but the real problem gets shoved into the cloud, right? Because that's where real horsepower, real computing, real large data and infrastructure lives. So the tip of the iceberg, I think, is mobile health, and we see a lot of trends there. But we should never forget that 2/3 of the iceberg is actually problems that have to be handled now somewhere else in the cloud. And that's where, again, big tech has a role to play. to really make it meaningful, you know.
Yeah, I think the next thing that we're going to see is the need for interoperability. So, I mean, it's a little bit self-serving on my behalf, but reality is that we're going to have a little bit of the interoperability discussion and have to get these devices where to make them even yet another order of magnitude less expensive is get that interoperability in place so that now you have devices that you can plug and play across the board. And you're going to have that ubiquity of interoperability to make it a consumer play as well. You know, today we still have integration issues. You have to, there's a lot of device integration that either the individual has to do or a service provider has to put forth in order to make those work today. And what we want to do is make that much easier. And I think that's the biggest next thing that we'll see is interoperability become the play in the market space.
I think from a clinical perspective, I see the walls of the office traditionally sort of falling apart, not in terms of the regular visits, but in terms of the division between the urgent care centers and my office and the hospitals. When you go to one of those facilities, you're going to be probably sicker. So when you go to the office, it's going to be more complex problems as opposed to simple problems. The hospitals will get more complex acute patients. So what's going to happen is there's going to be a shift of resources. So the volume and the resources on the hospital side and on the office side will be still the same demand, but that you're going to have more complex patients, and the healthy, more simple acute problems, more simple problems will be able to be managed remotely.
So from my perspective, I agree with all of that. I would add two things. One being the security of the data on it, who's accessing the data. And then the second, it's still, how do I reduce down the number of devices? Although we would love you to have multiples. In the clinical environment, they don't want to have as many. So how can I have my clinical data on one half or one persona of a device and my personal on the other half, and then the two never meet? So that's probably a bigger trend than I see on top of the security.